So this patient of mine is a 25-year-old professional football candidate. He's a linebacker. His pro day is on April 5th, and he is trying to be the best and fastest that he can be, so he stands out among the masses. So I was set to screen him, and I did a brief screen on him on the 10th of January. And so when people come in like that, you know, what are you here for? Well, they're here for an assessment. They're not really sure what they're here for. So I start the patient history a little bit. Can you tell me a little bit about what's been going on in your career? Have you had any injuries? And in this case, this patient had a left ACL reconstruction 4 years ago, and that was from a non-contact injury. And he was having a little bit of Achilles problem in the last year or so. He had a injection. He wasn't sure what kind it was, but it was the kind to untangle his Achilles, is how he put it. Right. So we know either it was a steroid or PRP, right? So that was
it also on the left side, Lynn?
All on the left side. Interesting.
The
right?
Achilles
And that's all the
left-sided as well.
Yeah, that's all the history I could get out of him. Right?
Okay.
So when I'm working with the athletic population, I try to get buy-in right away, because they're not used to seeing a little old lady. You know, they want to be in the gym with all the young athletic types, right? So I'll generally do a strength assessment first while I'm talking to them and ruling out red flags kind of at the same time. So I'm trying to get a good history there. So I sit them up on the table and do my thing. I do a little dural tension, do the gross screening. So in this case, found that he had decreased hip flexion on the left, and it was moderate. Kind of looked at me, was surprised that I could actually break him, but there was a significant difference. The other thing that we found is he had decreased plantar flexion on the left, and that didn't surprise either one of us, and that was a moderate strength too, right? So he could do about 6 reps compared to 15 on the other side, something like that. So a significant difference in strength. Okay. So we had something to work on. I said, well, that's interesting. And I started talking about, it's kind of interesting, everything's on the left side. So the education process kind of starts there, and we're talking back and forth. I go, well, let me see if there's something I can do that can change this. Let's just see what we have. So I'll do a movement screen, and I use video assessment because I'll do a GOATA assessment on most people. And I also do the McKenzie movement loss on video, because I think we miss a lot of the small details, you know, that our eye can't catch it. So when I did that, I could tell that.
So with every patient, you're getting.
Yeah, I try to do it with every patient.
Sorry, Lynn. Yeah, there's a little delay in our audio, so I apologize for talking over you. You're doing that. You're taking the camera out and videotaping with every patient.
Yes, I try to do that with every patient.
Okay, gotcha.
And it depends, you know, if you have somebody that's in significant pain, you know, I'll get right to it. You know, if it's a hard shift or something like that, you know, well, I'll take a picture maybe, but that's it. So as far as motion loss, he had just a little bit of motion loss in flexion, standing flexion. He could actually touch the ground, but you could see that there was a small area in the lumbar spine that didn't have a curve reversal. Okay. It didn't appear that he had any extension loss. He had a little tightness in left side glide. And that was about it for motion loss.
Okay.
So then I lay him on his back. I want to look at hip range of motion, knee range of motion, things like that too. So put him through that screen. And what was really interesting was he had a significant loss of knee flexion range of motion on that left side, where he had the ACL surgery 4 years ago.